Hello everyone, welcome to my online session. I'm Zhijun Guo from the Cancer Hospital of Santo University Medical College. As we know, a balanced diet is crucial for maintaining normal body functioning. We obtain essential nutrients through adequate food intake. Usually, we take the food or drink by mouth and enjoy its taste. It is a real pleasure. Do you agree? But unfortunately, for some patients, eating by mouth is not possible or is unsafe. These include, for example, premature infants, unconscious patients, or patients with dysphagia. So, what should we do to help the patients obtain enough nutrients? One common strategy is to provide feeding through a nasogastric tube, also called the entry tube. This chapter includes two parts. In part 1, we will discuss the process of inserting an entry tube. For part 2, we will focus on how to provide feeding through the tube. Now, let's go through the first part, insertion of an entry tube. After this session, you should be able to, first, describe the aims of inserting an entry tube. Second, verbalize the steps. Third, discuss the methods of conforming entry tube placement. An entry tube is inserted through one of the nostrils, down the nasopharynx, and into the stomach. In addition to providing a route for feeding, an entry tube may be inserted to empty stomach contents to prevent gastric distension, nausea, and vomiting, to take stomach contents for laboratory analysis, and for stomach washout in cases of poisoning or medication overdose. Now, let's look at how to insert the entry tube. Prior to assessment, introduce ourselves and verify the patient's identity according to institutional protocol. Then, we should check the patient's history for nasal surgery or deviated septum. Determine the patency of nares by asking the patient to breathe through one nostril while occluding the other. The nostril that has the greater airflow is preferred. It is necessary to determine the presence of gag reflex, assess the patient's mental status, knowledge about this procedure, and the ability to cooperate with the procedure. Basically, the nurse, supplies, and environment should be well prepared. It is necessary to ensure patient privacy. The supplies include large or small bore entry tube, 20 ml syringe, clean gloves, a cup of water, flashlight, swabs, gauze, safety pin, elastic band, label sticker, non-allergenic adhesive tape, facial tissues, hand sanitizer, water-soluble lubricant, disposable sheet, 2 kidney basins, and a stethoscope. Now, let's start the procedure. We will check the patient's identity. We should tell the patient that he or she will experience discomfort or gag during tube insertion. We can suggest the patient to raise a hand or finger to indicate distress and a desire for us to pause insertion for a moment. If patient's condition permits, assist the patient to a sitting or high-forward position. If not, place the patient in right lateral position. These positions will help passage of the tube. Place a disposable sheet over patient's chest, a kidney basin, and tissues within reach. Select the most patent nostril and clean it if necessary. Perform hand hygiene and don clean gloves. Next, we need to determine the appropriate length of tube insertion. How do we measure the distance from the nares to the stomach? We usually use the tube to mark off the distance by either of the following two methods. One is from the tip of the patient's nose to the tip of the earlobe and then to the tip of the xiphoid. The other one measures the hairline on the forehead to the xiphoid. This distance varies among individuals. We can use an adhesive tape to mark the length if the tube doesn't have markings. We will then prepare the tube. Lubricate the tip of the tube with water-soluble lubricant or water to facilitate insertion. Oil-based lubricants can't dissolve and could cause respiratory complications if the tube accidentally enters the lungs. Therefore, oil-based lubricant is not recommended. If a small bore tube is being used, ensure stylus or guide wire is secured in position. After lubrication, with patient's hyperextended neck, carefully insert the tube into the selected nostril and gently advance the tube toward the nasopharynx. Slight pressure and the twisting motion are sometimes required to pass the tube into the nasopharynx. If the tube meets resistance, withdraw and put it in the other nostril to prevent injury. Once the tube reaches the throat, ask the patient to flex the head forward. This position helps prevent the tube from entering the airway. Continue advancing the tube. Ask the patient to keep swallowing until the mark is reached. Why do we encourage the patient to swallow? Because this allows the epiglottis to cover over the opening to the larynx. When we finish insertion, ascertain correct placement of the tube. A number of tests have been proposed to determine the tube position. However, X-ray is the only definitive method. If X-ray is not visible, in clinical practice, we usually perform the following three methods. First, aspirate gastric content and trachea. Second, listen with a stethoscope over the patient's epigastrium for a whooshing sound while injecting 10 to 30 milliliters of air into the tube. Third, we should not see bubbles when the end of the tube is placed into water. If applicable, testing pH of aspirates is also recommended. If all of the above can't indicate placement in the lungs or stomach, advance the tube 5 centimeters and repeat the test. It is worth mentioning that we should have initial radiographic verification of the tube position if it is used for feeding. Once correct position has been determined, we should tap the tube to the bridge of the patient's nose, cheek, or earlobe and secure to patient's clothes as soon as possible. If the tube doesn't have anti-flux function, fold the end of the tube to prevent the gastric contents from flowing out. We can cover with gauze and put an elastic band around it. Place the label with relevant information. Dispose the supplies correctly and perform hand hygiene. Make sure relevant information is fully documented. Include the type of tube inserted, date and time of tube insertion, means by which correct placement is confirmed, and patient responses. We should establish a plan for daily entry tube care, especially oral care. We also need to conduct appropriate follow-up, such as patient comfort, tolerance of the entry tube, correct tube position, as well as patient's understanding of restrictions. So far, we have talked about the procedure and the considerations of inserting an entry tube. This flow diagram shows you the major steps. Finally, I would like you to pay attention to the following key points when performing entry tube insertion. First, perform a thorough assessment and get patient's cooperation. Second, gently insert the tube to an adequate length. Third, make sure the tube is in the correct position and safely secured. Fourth, withdraw the tube immediately when patient experiences respiratory distress during insertion. After insertion of entry tube, How should we administer feeding through it? This is the topic for our next section. Here are the references. Thank you for your attention. See you next time.